before you get started, let me introduce Adam Babitts to you. And we would like to also give you a little certificate of appreciation from all of us.
Oh, awesome. Thank you.
So there, yeah. We're so thankful that you've come. But who is Adam Babitts? Oh my gosh. I got his curriculum vitae, and there's such a litany of degrees and certificates, I just can't name them all off. So he got his doctorate at St. Mary's and has his OCS. He also is a professor at St. Mary's and has been doing that for a little bit. He's interested in research, and I think pretty soon wants to kind of marry the research of MSI and pain management as well. So I thought that was really interesting. But in looking over his vitae here, the most promising and exciting thing that I saw is that he and I have worked together, and he doesn't even know it.
Uh-oh.
We worked together, and we're medical volunteers at the 2016 Disneyland Half Marathon. And did you look at the medical tent?
Yeah.
So did I.
Was it the main one, or is it?
Yes.
I was not in the main one.
Sorry.
But I came in after to try to help out,
Okay,
so I probably saw you.
Yeah, so we've got something in common.
Oh,
there,
okay.
So I thought that was really interesting. So yes, he is more than accomplished to be able to teach this course to us. So thank you and welcome.
Yeah. So if you volunteer for the half marathon, you get free tickets, by the way, to Disneyland.
Except that now they're not doing it because of the new Star Wars land.
Oh, really? They're not?
No, not until that's all done. You can still do it in Florida if you want, but not here in
Okay. Well, I already started off with a lie then.
Yeah.
So my apologies. So I'm here to talk about the hip. Michael asked me to merge with chronic pain as well. So I'm going to start talking a little bit about chronic pain. Then we'll get into, again, why I love MSI and what it means to me. Before I get going, how many of you have taken MSI courses outside of people who've come here? Or even Claire Frank, things like that? Okay. And then how many people have taken chronic pain or pain science courses? Ken. All right. So, perfect. My favorite person to talk about is Adrian Lowe with chronic pain. So I use a lot of his stuff when talking about MSI and merging the two. And then we'll get into the concept that I think is most important into just really appreciating movement in general. And then we'll use it to look at 2 to 3, depending on how much time we have, movements, and see if we could pick apart people and what's abnormal in them. So why I got into MSI, I started off, just like Shelly was saying, I did an orthopedic residency where we did a lot of special tests, trying to figure out what the tissue source was. And I eventually just got tired of creating pain for people on their initial evaluation, giving them a diagnosis and then a treatment, and then going home and having them call me up that they're flared up, right? And then I wanted to figure out what can I do better for these people to get them to feel better, and when should I use my special tests? What is the right time to use one versus the other? So I'll get into that in a little bit. A great study that Adrian Lowe talks about, and then I figured I'd read it too, and I thought it was one of the coolest studies. It's a study based off of looking at people who've had back surgeries, microdiscectomy, and then they took half the cohort, and then they gave them the surgery, and they took the second half, they did the surgery, and they gave them a piece of their disc after, right? And they want to see, does that have an effect on how well they feel after the surgery, right? So then if you're thinking, okay, well, somebody receives a piece of their disc after the surgery, would they feel like their functional abilities and their pain is better after versus the people who don't receive it, or vice versa? So let's say people who think just the disc, they felt better, versus people who didn't receive their disc at the end of the surgery, who thought they had better outcomes. Okay, and then the rest I'll just say is still thinking about it, all right? So it was actually people who received a piece of their disc had better outcomes than people who did not. They tried to figure out why, right? Why would they feel better? Well, the people who felt or showed improvement because they received a piece of their disc, they knew something was taken out, right? They believed something was removed and the part was fixed. they found out that people who didn't receive their disc weren't sure if they did the surgery correctly or if enough was taken out. So it's that mental connection of, okay, yes, I had a surgery, it fixed something, but a lot of our pain comes from our brain, right? It's an output, it's how we process things. And then they went a little bit further, and they wanted to ask, what did these people do with the disc after they were given the disc? A lot of people showed everybody they knew or put it on their mantle because they were proud that something was fixed and I feel a lot better, right? So just something to think about. If we are going to give people a diagnosis of a tissue-based pathology and we're not going to refer them out to somebody to have something done, is that an appropriate thing? We're giving them some knowledge on something that might not be appropriate for them. So they might have a meniscus tear, but they're appropriate for PT. They don't need a surgery. Do we need to tell them they have a meniscus tear or just say, I did some tests on you that tells me you're appropriate to see me? Or I did some tests on you and you might be better to see an orthopedic surgeon instead of trying to build up that diagnosis or tissue pathology problem that they might think they have, because we have the internet now, right? People are going to start looking up things. It might cause another problem down the road, right? Oh, I don't have clicking or popping when they came to see you, but now that they looked it up online, they'll hear every click and pop that happens at their knee, right? And that could perpetuate a problem down the road where, yes, they might have a surgery or you might get them better, but there's always this lingering discomfort that won't go away because they have it stuck in their mind. They have a meniscus tear. So, Adrian Lowe, something he talks about is the medical model is really based off of tissue pathology, though. And we found out that just treating that pathology won't have an effect on their function or pain. A surgeon will improve that, a rotator cuff tear. They'll go in there and fix the rotator cuff. Meniscectomy, they might take a piece out. ACL, they're going to fix it. Us as rehab specialists won't fix that, right? We just give you a healing environment, and then the symptoms go down, inflammation goes down, and they return back to function. So if we stick with this tissue-based way of thinking, we're not going to get them to be 100%. We need to improve their function. That's what we do as specialists. That's our niche. We fill this huge void in the medical field, right? A doctor could give a surgery, or they could give you medication, but they don't really give you anything in between, right? Sometimes they have that special sheet for back pain where they have the 3 exercises or 5 exercises, and then the patient comes in and says, I've tried this, but it doesn't work, and then you realize it's the wrong exercises for them. Right? Because that's our specialty. We have to get better at looking at movement and improving their function. So a great statistics that he talks about are even people who have bulging discs might be asymptomatic, right? People who have facet dysfunction might be asymptomatic, right? Rotator cuff tears, you could be perfectly functional without pain having some rotator cuff tears. Yes, if you have 3 of them fully torn, you're probably not going to be able to raise your arm. But if you have partial tears, you could get away with improving the way the other muscles work and improving function to bring down inflammation and letting those tissues heal. So something him and his team talk about are, these are the factors that will lead to chronic pain, right? The things in blue are things that we can actually have an effect on, right, as physical therapists. We could improve their knowledge and logic on some of the symptoms that they might be feeling. Okay, well, you aren't having pain from maybe a degenerative disc. You might be having pain with just a certain movement, right? Or if you have a huge bulging disc, you would have pain a lot of the time, but you only have it when you get out of the car and then it goes away. We're trying to dispel a lot of the things that we find on the internet. Patients always come in to me all the time and said, I looked up all these things, I saw all these YouTube videos, and they did all these exercises for this pathology that I have, and it's not better. Well, do we have to let them know that you don't need to look at the words on the internet, you need to understand what the underlying issues are that's causing your problem? Do we just need to get them moving, physical fitness? Let them know that maybe you need to be a little bit healthier on what you eat, or just get out there and move. Right? I have a lot of patients, I don't even give home exercises to. I just say, you need to get up and you need to go on a walk once a day because you're just going to start to feel better. Get the endorphins going, get the heart rate up, right? Because as we get or people get lost in chronic pain, what happens is they start doing less and they start feeling worse, right? So sometimes it's as simple as just educating them to move. And just general fear and anxiety. Do you need to be afraid of these things that the doctor tells you, or that 5 different doctors told you 5 different reasons why you have this pain and now you're really afraid? And do we have to break this down and say, okay, well, it's only when you move and we just need to improve the way you move? Any questions so far on this chronic pain part? All right. So why we want to get into movement is basically what I've been talking about, right? We need to fill this huge void in the medical field, and that's our specialty. So the principle that I think helped me the most with seeing and appreciating movement is PICR, just path of instantaneous center of rotation. It's basically the idea of if you're going to move a joint, it should move a certain way. And if it doesn't move a certain way, we have to ask why, right? So let's say we take the picture on the left. If I tell my patient, I just want you to bring your leg out to the side because I want to see hip abduction, right? And we see her do this. Would you say that she would be on point in doing abduction, or is she compensating somewhere? So we're just going with the one on the right. Oh, or excuse me, the left. Right when I'm standing this way. Good catch. Yeah, she could be leaning. All right, so we got some people saying leaning. What goes through my head is I think of planes of motion, right? If I'm looking at hip abduction, I'm seeing what's the pivot point, right? So I would expect the pivot point to be right there at the hip, right? But for her, she's actually pivoting up a little above the umbilicus, right? So she's bringing her leg out to the side. My first thought would be, why is she doing that? Why can't she just bring her leg out to the side just like that, right? Why is she compensating to come up? Is there a weakness of the hip abductors? Is there relative stiffness of the adductors, right? So then my follow-up test would be, okay, well, I see how you move. This is your preference, right, for movement. Can you just bring your leg out to the side alone, right? Because if they can't, then there's a problem, right? Every time they go to kickboxing, she's going to be doing this and she has right-sided lower back pain. What is she doing to her back, right? She's crunching down on her back. So I think planes of motion, if we're looking at abduction, what's happening in the frontal plane, right? Let's say, we'll just use her as an example, but she's not doing it. Let's say her toe is pointed out to the right with her right leg. Then a question would be, why is she rotating an external rotation? Can she do abduction alone, right? And then do we have to train her to keep the leg in neutral position? She goes to kick in kickboxing, right? We don't want her to keep on doing this. Again, she's getting rotation through her back. Can she just get the hip to do its job? And why can't it? Let's say we take the individual on the left. We're just looking at knee extension. What could be a problem with how he's doing this? And these are just pictures I pick off of Google, by the way. I don't know these individuals. Yeah, so a little bit of external rotation, right? Is external rotation bad, though, in terminal knee extension? No, we want it, but we only want 5 degrees, right? That's the screw home mechanism. So right there, I could tell you right now, is more than 5 degrees. He's coming in for right knee pain. In my head, I'm thinking, why is he rotating so much from the tibial-femoral joint right now? Every time he lands when he jogs, is he landing like this, right? Do we have to figure out what could be more stiff, whether it be one hamstring versus the other, or what might be not strong enough, right, to get him to accomplish his goals? So again, planes of motion, transverse plane versus frontal plane. Are they pivoting where we want them to pivot or rotate from where we want them to rotate? And if we don't see that, why don't they? And we're going to go through some tests in a little bit where we're looking at quadruped rocking. We're going to be looking at prone hip extension. And we're going to look at, if we have time, seated rotation. And the reason why I only bring up seated rotation is in my population, sometimes you get people who it takes them about 10 minutes to just change positions on the plinth. So it's just to check glutes and hip function. It's just a good screen for me. Any thoughts or questions on that? All right, so let's get to the fun stuff. of looking at these. So am I using you, Michael? Oh, perfect. So that's why you changed into shorts. So if everybody could come up, and then we'll look at quadruped rocking. And again, I'll let you know what goes through my head as I go through function, or looking at movement. All right, and is it okay if I lift up your shirt a little? Okay. All right, if you get cold, let me know. All right, so first of all, you look at the resting position, right? Where does he like to be in? So yeah, yell it out. Go for it. What do we see? Yeah, he's pretty flexed through here, right? Why can't he just let everything collapse down? Is it a stiffness thing of the spine? Or is it just he's just really tight of his abdominals and he can't let it go? Sitting position, he's probably a sloucher potentially, right? Is it a muscle length issue, or is it a spine that just won't move? What else do we see just in resting? Posterior pelvic tilt, right? I might be thinking, is there a length issue right here? Is there potentially a joint hypomobility issue? Is there a gliding of the hip joint? We'll talk about gliding in a second, but one of the more common femoral syndromes is an anterior glide. If his anterior or his femur is sitting a little bit more forward in the acetabulum, he can't sit his hip back because it's going to abut against something, right? So these are just my thoughts looking at resting position right now, because it's going to guide when he moves what might stand out, right? So the other thing is that I see is he likes to keep himself in slight external rotation, right? He doesn't want to keep things in neutral. Did you have a surgery back here, or is it just? This one? Yeah, on the left side? Okay. So if you have any pain throughout this, you let me know. All right, so yeah, I'd be curious why he brought his legs together, right? Is it his tight, small, or intrinsic external rotators? Because he sits in slight external rotation and he does have limited range of motion. Again, these are just my thoughts. So now we're going to think planes of motion. We have the transverse plane. Does he rotate through something when we see him move? Does he go into sagittal plane? Does this flex more? Does this not flex enough? Frontal plane, does he side bend? And then what also happens to the femurs? So this is just how my mind works. I want you to rock back, sitting towards your heels. You keep your hands right there. Yeah, so it would be nice if he didn't have shoes. So yeah, let's have you scoot back. And the table should hold you. All right, and then come back up. So again, just yell out whatever you see. There's no wrong answer. And just keep on going slow, back and forth. I'm just going to look from the back because... Yeah. So good, yeah, you're looking at shoulder blades. But let's just keep it down here, or else I'll get lost once I start seeing cool things up top, right? Even though we're supposed to be, yeah, it's supposed to be the hip though. But yeah, I agree. What else are we seeing? Excuse me. Yeah, so he still stays in the posterior pelvic tilt. This doesn't get more external on the right. Yeah, completely agree as he goes down. What happens? Does he actually change positions in transverse plane? So rock back, he's actually a little bit higher on this right already to start with. And he stays a little bit high. So then would there be a gliding issue here, or is it just position of the femur, something that's going through my head? So come back up. Do you have any discomfort anywhere in the back?
No.
Just in the front. All right. So secondary tests, what they are just fixing what's wrong, right? And then seeing if it feels better. So let's go. You said external rotation. What I would do is just try to keep them in neutral and see if that changes anything, right? So I want you to sit back. Better, worse, or the same? Yeah, it looked worse to me too. All right, so let's put him back in his comfortable position. So now let's take that one away, right? It's not high on my list of something that could be a problem. So could it be a gliding issue? Does he just need to get his femur to glide back as he rocks back? So what I'm going to do is get my hand in the crease, and then I want you to sit back towards your heels. How does that feel? Better, worse, or the same? How's that feel? Oh, better, worse, or the same? Okay, come back up. But this leveled out a little bit more, right? And what I did like is this got a little bit better. He's still a little bit more flexed. So what I might do is combine the two, right? Let's work on hip position. So I'm going to put you in a more neutral position and abduct you, because I might think it might be a position of the joint. And then also glide it and give it a go. Tighter. Okay, back up. Now I'm going to try to keep him in external rotation a little bit there and glide him. That's better. And come back up. So now I'm just curious, does he actually rotate through his femur? So give it a go on your own. Oh, he does medially rotate. So this you can't really see, you have to feel. You could get your hands right on here. Maybe this is a way for you guys to do it, or you can put your hands here. I like to just feel. And as he rocks back, rock back, you can see he just immediately rotates a little bit, right? So even though he sits in external rotation, his femur is immediately rotating. This might be just your driver right there. Give it a go. How does that feel? Okay, do you still feel that tightness? All right, so he is gliding. So normally, I mean, I'm getting curious. I'd like to do a full eval, but we're just going to look at quadruped right now. So I'd suggest, like, you have partners, right? Partner up. Should we do two or just go through, Michael, the quadruped? Do two? Okay, yeah. So, yeah.
I was wondering, do you start from the center, or you work from maybe the knee round up to where you feel like,
What's a good starting point?
Yes, because as you started correcting his leg and his hip and his knee, he started side gliding to the left side of the hip.
Oh, to offload?
Yes.
Yeah, and I also brought him into abduction to take some pressure off of the hip joint too. I look for just the biggest thing that stands out. First thing that I saw was the external rotation. It just got me curious, right? The other thing was up here, right? So I glided back, which improved his pelvic tilt, but I think he just automatically corrected himself. And then the last thing that I just caught was that rotation at the femur. So that was subtle. And I just go through my checklist of just really what stands out the most, right? What do you see first? It's usually the biggest impairment, and then work my way down of, okay, well, do I see something else? And then what's the next thing I see? That's just how I work. All right, so let's look at prone hip extension. Other thoughts or questions? Yeah.
Did you know, like, as you're correcting, then he does so how much do you spend time trying to make it look nice, or do you just move on and think,
It depends on his irritability too. If he's highly irritable, the first thing I'll do is whatever just feels better for him, right? If he's low irritability, I'm going to start correcting a lot of different things to make sure he looks pretty throughout his motion, right? But my ultimate goal is to make him feel better, right? High irritability, if I could get him to feel any better, I'm just going to go with that route, even if it's a little bit ugly elsewhere, and just limit the range of motion that he rocks back. So we're going to look at prone hip extension, because we could look at gliding there as well, and it does tell us a lot. So again, same thing, we're going to look at transverse plane, we're going to look at the frontal plane, and then we're going to look at the sagittal plane, right, just to see what goes on. If we want hip extension, the hip is the only thing that should extend really, and then we get a little bit of compensation from the back, but this needs to work first, right? So on the right, I just want you to pick up your right leg off of the table. All right, and then back down. What does that feel like to you? Feels like you're using your back. One side versus the other, or just the center? On the right side here? Okay. Let's lift the left side. And back down. What was better about it? Okay. So yeah, he's initiating down here more. I would palpate to see what I feel. The other thing was height for me. One was way higher than the other. Do this side one more time. Yeah, and you can see that kicking in. And then back down. And then you also see a little bit of rotation through the lumbar spine, right? Do the left side. And I don't see anything move here. This is where his symptoms are, right? I'm going to stay a little bit closer right now. So come back down and just give him a little bit of stability right here. And I want you to pick up that right leg. How does that feel? Better, worse, or the same? Okay, and back down. So that's something I'd look at. I'd still see the other things we talked about, right? So we had rotation here. We looked at timing. So I want you, with my thumb, with your glute, I want you to tighten up that muscle right here. Up, relax. That was all hamstring. Pretend like I have a $100 bill between your cheeks, and don't let me grab that. And go to lift up. And back down. Tighten up again. Tighter, tighter, tighter. There you go, now lift. What does that feel like?
Feels like I'm a $100 bill.
And I'm not getting it, right? How's the back?
It's okay.
It's okay. So timing was an issue too, right? So we might have to combine how does he stabilize here and how does he turn on right there. Was there a third thing that we talked about that I forgot? I pointed out. So we got the rotation. Okay. So we're going to correct the two, see if you can fix it, and then we'll talk about gliding of the femur as well. So I want you to try to tighten up your abdominals just a little bit, just to give you a little bit more stability. Squeeze your cheeks together. Perfect. And then go to lift. Good. And then back down. Then the right side, or left side. Still getting a little bit higher though. So we might need to get this to turn on a little bit better. Or does he have something in the front of his hip that's limiting him, right? Again, we didn't do a full exam. It's just a lot of speculation with things. So if we want to look at gliding, what we could do is you're just going to take your fingers, grab around the greater trochanter, and see what happens. Again, if we're going to think PICR, if there's a rotation going on at the hip, we want it to be almost like a rotisserie, right? We don't want any extra movement up or down. So you're going to come in here, and I'm going to have you pick up your right leg and back down. Not too much, not too bad. And then on this side, and back down, but better. So he's able to pivot through here. One more time. Good, and back down. So if he had a gliding issue, what you would see is all of a sudden this is going to shift down that way because he might have relative stiffness of his hamstrings, and then the anterior part of his hip is a little bit loose, allowing that joint to slide forward, right? So going back to his discomfort that he was feeling in the front, that could be a reason why he's having it if there is a glide. We did quadruped rocking with the posterior glide. There wasn't too much improvement. It was mostly the rotation going on here, which we actually didn't see in prone. So I'd give him the two treatments, really. He's got to get this glute to fire a little bit better with his core a little bit stronger. And then he needs to, when he does quadruped rocking, grab onto his femur and make sure it doesn't dive into medial rotation because we don't want to keep on causing irritation at this joint in the front. And those are my thoughts right now, but I think we should look at quadruped rocking, prone hip extension, and think planes of motion, unless there's questions right now.
Can you also test prone hip extension for knees bent?
Oh yeah, just to see if it's a different lever arm.
Yeah.
Good. And back down. So then he goes into a little external rotation right there. One more time. But he does a little bit better. How's your back feel? So you change the lever arm, right? But now he goes into a little external rotation. What I want you to do is make sure this stays right there. See if you could lift it up. Yeah, back down. So is he getting his small little external rotators to help him out, right? Instead of getting his glute that we need to turn on. Because we already saw that in prone hip extension, he didn't want to turn it on all hamstring. So yeah, awesome. Good thought. Other questions or thoughts? All right, so break up into groups and let's look at quadruped, rocking, prone hip extension, and think just planes of motion, right? What looks weird in this plane? Does anything look weird in frontal plane versus sagittal versus transverse? Oh, thank you. So then I would have them just lift your leg up and then back down. So not too much of a glide, but he goes into a lot of external rotation and his back moves a lot.
Yeah, this one has a little more range. But then still also external rotates also.
So why is he getting his small external rotators, right? Instead of just the glute to keep him in the sagittal plane, would be my thought, right?
Waters one more time. Can you lift again? So then when you lift your leg, can you try to keep it pointed toward the ceiling? How does that feel?
Better.
Struggle.
Yeah, no pain.
Really on now.
Yeah. And we didn't do a full exam. Does he have shortness of his hip flexors too? That could just be it, right?
Yeah, that's kind of what it seems like right now, because when we're providing all the stability, then he feels more effort, but then he can't do. He can still do it.
Yeah. And then yes, it's not a Thomas test, but what we could do is, yeah, just what is his actual available range? Can he get there, right? Because if he can, then it's just a strength issue, right? Relative strength issue.
Hip flexor flexibility to see if that's causing.
Yep. So it could be hip flexor, right? And we could do Thomas tests, or we could just see, yeah, just does he get to the range that we want, right? Because if he does have the range and he doesn't get there, I would think, why doesn't he get there then? Right? And then is it core weakness? It's hard to say, right? We have grades for core, right? But really in the end, why doesn't he turn it on? Would be my thought, right? So is it a timing issue or a relative strength issue, right? Because we always have these black and white grades, but it's always relative to the rest of the body, right?
And then also just the coordination and the timing of the whole thing. Not necessarily just pure strength, but
Yeah.
does it come on at the right time?
Yeah. Does he just have a weird pattern, right? And where did it come from? Did he have an ankle sprain where he wore a boot and then all of a sudden he had to compensate? Boot's gone, and this was like 8 years ago, and he just kept this little pattern over and over again because his brain's telling his muscles what to do right now, right?
You're psychic.
Did you have?
Wore a boot.
Yeah.
When did you wear the boot?
4 years ago.
Okay. On what side?
One more time.
I think it's on my left side. Over right side.
Yeah. But something put him off balance, right? And his brain had to reprogram in order to accomplish the goal, right? And everything's gone, and now he just kept the program. The left side, right? Just slight medial rotation. These are epicondyles, right? So she's just a little bit here. And now she just put herself into a little bit of medial rotation on this side. But her resting position was a little bit better right there. So this, she's already presetting something. So then I'd be curious what happens when she does go into an extension.
Would you correct that? Or
Not early, because I just want to see what happens. A lot of it's just seeing what happens, because you're trying to build a case of where you're going to focus your attention to. The trouble of looking at movement is there's so much going on, so how do I focus? So this just gives me an idea of where to focus first. So then I would have her right side, just lift your leg up. She actually does pretty good, right? With the rotation. But she looks like she might be gliding. And relax. And up. And it's subtle. It's not huge. But if you could feel, put your hands right here. It's not a big one where I'm concerned. But you'll just feel something press into your fingers right there. Uh-huh.
So is that more of a motor control or just dominance side, or is that just that you really have like a weaker left glute potentially that I can't fire that, or more hamstring dominant?
Yeah, so is it a weakness thing? I usually don't way heavy on weakness for somebody. I mean, you're neurologically intact, you're active. Relative weakness, well, I wouldn't say just do glute sets, right? I would probably change your motor pattern. Why are you doing it that way would just go through my head. Why do you use your hamstring? Or did you do rotational sports before, right? Sometimes with that, I would think, okay, well, how are you planting or how are you landing and what muscles are you using?
Okay.
But that's going way past, I think, what we're looking at. But it's a great way to think, right? Do I just have to work on strength, or is it length, or is it a motor problem? Right? Does that answer your question, or does it just make it more confusing? Okay. Just coming anterior, you just give that support right here. Boom. And then go to lift up. How does that feel?
Pretty comfortable.
Yeah. So did you have a glide? This is late, but
Yeah.
go for it. Yeah, you do come forward. It's not significant, but what came first, right? Was it the laxity anterior of your hip, or is it the hamstring driving that femur forward? Getting hard to say, right? Because if you have a bad pivot point, maybe it is just your hamstring that's overdriving, and that's why your glute can't fire.
Did you see a difference when you brought it posterior?
With the timing?
Yeah.
I didn't look at the timing. I just felt that there was still a timing issue. So first, let's just go on your own. Lift up. Oh yeah, that's way late. All right, and give it a go. Yeah, you're still late.
Okay.
So then I would say they're two kind of separate things, right? One didn't drive the other, else you would have seen a correction. Right? So I was going to go over seated hip rotation, but we don't have time. Principle's the same, right? What's going on with the hip? Does it stay in the transverse plane when you're seated, or does it go into flexion? Does it go into abduction? Does the trunk hike up, right? Or can we correct it, and does it make them feel better? Just think planes of motion if you're going to get anything out of this lecture. If something looks weird, is it not staying in the plane it should be? If I correct it, does it feel better, right? But I guess we're going to leave the last 5 minutes for Q&A, right? So questions, thoughts, concerns? Actually, my spiel with my patients. Any cool things that we saw, or things we've changed on somebody and it worked?
Everything.
Where to start, right?
Because the high thoracic flexion, and then he rotates down through his pelvis, so the whole thing was like a snake.
Did you correct a certain area and then it helped them, or is there discomfort associated? Okay.
We just had to try to keep that area flat so that and to see if it really moved through his hips, so he would move more naturally through his hips.
Okay.
And it was harder, right? Yeah. If we took that out of it, it was well.
Yeah. And we only have an hour. We can't go into really in-depth stuff. And what was exciting, and it seems like a lot of you have been exposed to some of the things with Joanne coming in or Maiko coming to talk about stuff, is great questions, right? Because you're thinking beyond what we just talked about. You're already thinking the next step. So it was exciting working with everybody. If you don't have any other questions, feel free to email me. I'll leave my email with Michael if you have any questions beyond this too. Yep. Anything?